we have Dr. Govind Nair. Dr. Nair earned his Ph.D. in biomedical engineering and medical physics from Worcester Polytechnic Institute and University of Massachusetts, where he developed MRI techniques for the retina and imaging markers on models of retinal degeneration in rodents. During his postdoctoral fellowship, he worked on developing specialized MRI techniques and markers of disease progression in patients affected by ALS. Currently, he is a staff scientist and director for Quantitative Core Facility at NINDS. Today, he will be speaking about visualizing cortical lesions in vivo using lessons from Postmortem MRI.
Okay, can you see my screen?
Yes, perfect.
Thanks. Thanks for the introduction and thanks for inviting me to speak here today. I think, as far as quantitative imaging goes, this presentation is a little less on quantitation, but I think I hope that I can convey what I'm trying to say in terms of the very basic way of quantitation, which is just counting. Okay, so, all right. So I do have, we have applied for a patent for one of the sequences that I'm going to discuss in this presentation. So I just want to put that out there as a disclosure. I still can't see the top of my screen, so I'm having a little bit of trouble. Okay, all right. So as an outline, so I'm going to talk mainly about cortical lesions and how it has been detected in the past and how we have used postmortem imaging and pathology to help design a new pulse sequence that can image it better. But I'll start with some brief introduction about multiple sclerosis. So MS or multiple sclerosis is an immune-mediated disease. What it means is that there's an abnormal response of the immune cells that causes it to cross the blood-brain barrier and sort of attack the myelin and oligodendrocytes that can lead to demyelination, axonal loss, and neurodegeneration. The cause of this abnormal response of this these inflammatory cells, did I say oligodendrocytes? Sorry. So inflammatory cells is not really known. There is a slight preponderance of MS in families. There is a higher incidence of MS in northern latitudes, and there is also various pathogens that are implicated, like EBV or Epstein-Barr virus. But it is really not pinned down. And but suffice it to say that about 1 million people in the US, 2.5 million people are affected by it worldwide, and this is what it looks like. So every attack, so there is this, you can see this pale discoloration in the white matter and maybe even in the gray matter here, and in the deep gray matter over here. So it basically this happens because of demyelination, and this is an attack. And it happens in sort of a pseudo-random fashion throughout the brain, and it also happens at any different intervals in time. So that is the basis of MS diagnosis. So if you look at it with some myelin stain, you can see this LFB, or Alexa fast blue stain for myelin. And you can see that there is complete loss of myelin in this area, this complete discoloration here. And also you can see some pallor in the deep white matter. And this is how it looks in the MRI. So this is postmortem MRI, and this is the again as the corresponding surface of the brain, fixed brain. And you can see that MRI is extremely sensitive to these what we call lesions. And it happens that MRI is about 50% more sensitive to lesions than what a naked eye can pick up when cutting the brain, which is a good thing because you can have patients, you can have patients undergoing MRI at different times, and it is a sensitive marker for patients that might be failing therapy. So, clinical management may need to be changed, or you could observe them for how well they're doing on the medicine. But it's also very important for research purposes, right? So you could have, this is a diagram from a clinical trial that I was a part of a few years back. So you could have patients randomly split into two arms, one with a placebo arm and one with active therapy, and you can monitor these lesions or these incidences that's happening. And the aim, of course, is to account for change the trajectory of the disease. So if a person is on active therapy, what you want to do is to maybe slow down the disease progression so that the prognosis can be better, and that would be a successful therapeutic trial. Of course, this also means that the variance here is low, or you do a sufficiently high sample size so as to be able to detect these changes. So the more sensitive these measures are, the better it is for the clinical trial. And we have seen that just looking at lesions may not be giving you the full picture of the clinical disability. So here on the x-axis is the flare lesion load, and on the y-axis is the various clinical measures. And what we see is that there is some correlation, but it's really not perfect, right? So you would expect that as the patient develops more and more of these lesions, you would have, the clinical scores builds up. But that is not really true. And this is at a 1.5 Tesla, and this is at a 3 Tesla, and you can see that it's the same patient. So you can see that it's better in the 3 Tesla, which means that, even MRI is missing something, right? So there are some lesions that are missing, or, it's not as sensitive as we think it is to detecting these lesions. And the second part, of course, is that there are various types of clinical measures that can be done. So there are some that are sensitive to motor, there are some that are sensitive to memory, and it may not be that we are capturing where the disability is occurring. So these correlations here, you can see that, at best, you can probably explain 50% of the variability of the clinical score by lesion volume. So that leaves a lot to be desired, right? So, and there could be various reasons for this. And one of the main reasons is that not all lesions are the same. So some lesions might give you some very high disability, whereas some could be completely silent. There will be no clinical effects at all. And that depends upon the location of the lesion. Also, there are T1 black holes, which are thought to be more destructive lesions. So some lesions are more destructive than others. And we have recently come up with some imaging options for looking at smoldering lesions. These are lesions that continue to have neurodegeneration. So they never stop. So multiple years later, they are still active. So that would be something to look out for. There's also distal effects, right? So if there is demyelination at one site causing axonal transection, that could be that particular cell body, which is located distally, could be dying, and that would cause connections to change. So there is a distal effect, the atrophy that is caused by the lesions, that could also be playing into this clinico-radiological paradox. Then there is, of course, the spinal cord. So there is less reserve in the spinal cord, so a lesion might be more may lead to more clinical effects in the spinal cord than in the brain, maybe. And then there is diffuse white matter damage that is not particularly a lesion, but we saw in that staining how there's a little bit of heterogeneity in the stain. On the other side, the brain is an extremely versatile organ, so it's got plasticity, so it can compensate for some of these clinical deficits. So that is the other side. And we have already heard many techniques to look at these subtle changes. So we heard about the T1 and T2 maps, or R1, R2 maps. We heard about susceptibility. We heard about inhomogeneous empty and magnetizing transfer. And we're going to hear some about diffusion-weighted imaging. And the last talk was about myelin water fraction. So there are so many different techniques that are there to kind of try and figure out how much damage is happening in the brain. But what I'm going to talk about is mainly cortical lesions. So if you look at a stain of a person, these are two people who have died after a long-standing MS disease. So this is about a decade, 13 years, and this is 16-year-old of disease duration. And what you can see is that there are definitely white matter lesions that are in green. There are deep gray matter lesions in blue here. But there is also this orange, which is the cortical lesions. And it is extensive. And cortical lesion burden can be 2 or 3 times as much. But these are people who have died, right? So these are the terminal, they have carried the disease for a long time. And it is also thought that a cortical lesion is mainly responsible for progression of the disease when there is no active site of demyelination. So it is important to look at this, but unfortunately, MRI is not sensitive. So if you look at this image from FLAIR and in T1 weighted images, you can really not see the cortical lesion as much as clearly as you can see the white matter lesion. So you can imagine that you end up hunting for these little hypointensities in the brain that may be very responsible for these progression, but it's we think that we're seeing only a small fraction of it in routine imaging. So there are techniques that have been developed for looking at specifically cortical imaging. So this is a cortical lesion. So this is double inversion recovery sequence. What it does is it suppresses both the white matter and the CSF. So the only thing that is shown here is the lesions and the gray matter one. And you can see that we pick up a lot of these cortical lesions that cannot be seen on the FLAIR or the 2D TSC. So that's one way to do it. The other technique that was proposed is called the phase-sensitive inversion recovery. So in this case, you can see the lesions is dark. So here's a lesion right here that is totally missed on the routine FLAIR image. You can see it on the double inversion recovery sequence, right? So that's there. But unfortunately, double inversion recovery is kind of susceptible to a lot of noise. So there's a lot of false positives in this. So counting these lesions can become tricky. But using both PSIR and double inversion recovery together gives a 400% improvement in detection rate of these cortical lesions. So, but what we also know is that higher the field strength, the better it is for detecting these cortical lesions. So this study uses T2 star weighted imaging. And here you can see, so this is postmortem up here, and this is in-vivo scans up here. And you can see these bright regions that correspond to cortical lesions. So this is definitely promising, but this is high field, and high field may not be accessible to a lot of people. So we wanted to come up with some sort of technique to bring this imaging to low field. So the other technique that's used in high field is the MP2 range. So here you can see the lesions is dark spots in this cortex here. And you can also see it in the T2 star, right? T2 star GRE shows it better than the T2 star EPI. And here's one that is really subtle. And you still need to hunt for it, right? Even at high field using MP2 range, it's not easy to just pick it up like that. You need an expert. So one thing that we saw was that the white matter lesion load did not correlate well with the cortical lesion load. And that is interesting because so if it was totally correlated, you would not need to measure both. You could just measure one and you could say a lot about the other. But here, since it's not correlated, so this could explain some of the variabilities that we see. So some of the differences in the clinical and the radiological aspect of the disease. So I also want to show that cortical lesions are of multiple types. So there are these type 1 and 2 that seem to touch or lay right next to the white matter, and type 3 and 4, which seems to come in from the PIA, from the CSF region. So this is from the meninges, right? So, and it is thought that this lymphoid-like tissue play an important role in making these, at least the sub-PL lesions. These are called the sub-PL lesions. So either through making cytokines or direct infiltration into the cortex. So this is the meningeal or the leptomeningeal space here between the dura and the pia, and these substances can cross over into the brain and start this process of demyelination. So in fact, if you look back at the histology that I showed before, you can see these little dots that they have pointed out in their paper, which I have highlighted using these blue arrows here, that these little dots are meningeal inflammation. So it seems to be that there is a meningeal inflammation associated with most of these cortical lesions, which was encouraging because we have Danny and John Buttman at NIH have been noticing these bright spots in the meninges after giving contrast agent and doing a FLAIR sequence. So if you do a FLAIR 20 minutes after contrast agent injection, you can see these bright spots, and these bright spots seem to correlate. So they're very tiny. So this is the same person, same lesion in all three axes, and you can see that it's not more than a couple of millimeters across in any other plane. So it's very tiny, and it is it seems to be hinting to these follicles, right? So this is another image showing pre-GAD T1 and FLAIR, and post-GAD T1 and FLAIR, and the only image that you can actually see it is in the post-GAD FLAIR. So it is not easy to pick up at all. So the other thing that we noticed was that unlike white matter lesions, these leptomeningeal enhancements or LMEs continue to enhance many years. So every time, so this person came back to visit for a follow-up visit every year, And we could see that it was enhancing into 2010, 2011, 2012, 2013. So we have seen that these things very rarely disappear. Yeah. And you can see that it's very consistently there, irrespective of scanner and a little bit of protocol independence. So it is very easy to pick this up. So it so happened that this person who came this person that we're seeing the images of here, died and donated the brain for research. And we fixed the brain, we put it in formalin, we evacuated the air bubbles and scanned it at the 7 Tesla. And this is the kind of images that we can get. So this is a 150 micron isotropic image of the whole brain. And you can see the cortical lesions here very clearly. So postmortem, you can see a lot more than in vivo. Of course, the SNR is also pretty high. And we can take these postmortem images, make a 3D rendering of that, make a box that this, cut out this the shape of this brain from the box, 3D print the box and lay the brain and cut it. So what this gives you is 100% correspondence, or very high correspondence of MRI and pathology. So we can directly know where exactly the cortical lesion. These are small lesions, so to find them in the brain would be very difficult. So this kind of method helps us find those lesions. And here is a cortical lesion again, in vivo and postmortem. And you can see that we have identified the exact sulcus. Of course, you don't have GAD here. So, but there is a lesion, cortical lesion associated with this LME, which was very encouraging for us at that time. And when we did the histology, we can see that this space is chock full of inflammatory cells. So this indeed was showing us inflammation, which was exciting. So we were thinking that we got a surrogate marker for cortical lesion. However, when we looked at other diseases, we saw that this LMEs could be seen in HIV, even a rhesus infected with HIV. So that was sort of more broader than what we were hoping for. In fact, in MS, only 25% of these subjects showed LME leptomeningeal enhancements. The same case for HIV, and even a couple of healthy, one healthy volunteer also did show leptomeningeal enhancement. If you look at the odds ratio, it seemed to show that LMEs were associated with CNS inflammation, not limited to MS. So that is there. And also it is unlikely that all these LMEs were associated with cortical lesions. So it could be that there is inflammation in the meninges that is not yet transferred into the cortex. So that part was disappointing in that we were not really getting to the cortical lesions. So then we decided to do, look at the cortical lesion per se. So we got these 2 blocks of tissue. So there's one from normal appearing cortex and one from a cortical lesion. We took a small slab of the, it's a tiny piece of tissue from both of them, and we did very high resolution imaging. So this is imaging at 18 to 25 micron isotropic resolution, and this is the normal appearing block. And here you can see multiple things. So you have these punctate hypointensities. I don't know how well this is reproducing on the screen, but there are these punctate hypointensities. There are these linear hypointensities that are, it's like lines over here. There is this patchiness in the white matter, and there is these hypointensities around blood vessels. And then and when we look at the block with the lesion, you see the same thing. You see those tiny dots, the punctate hypointensities. You see some linear hypointensities in the gray matter. This is the normal appearing gray matter. We see the patchiness in the white matter. And you can see some hypointensities around blood vessels. But if you look at the lesions, you lag these features. You lag the punctate and the linear hypointensities. So we wanted to know what was causing this. So this is MRI. This is DAP Turnbull, standing for iron, and this is LRP PAS, standing for myelin. And we found these dots, the punctate signal corresponding to this. So you can see that the MRI and the histology is very well matched. So it's very easy to figure out what the signal is, right? So you can see those punctate hypointensities. You can see the linear hypointensity or linear signal here, right there. And you can see the patchiness in the white matter. And you can see some signal around blood vessels. And here, if you look at the myelin stain, you can see those linear hypointensity, which is basically myelin in the gray matter. But most of the gray-white contrast is coming from the density of myelin in the white matter compared to the gray matter, and that this is all known, right? So we are very excited to see that. Okay, so there is iron is the main source of the signal here, except for gray-white matter contrast. And of course, when you look at the piece with the lesion, you can see that iron is actually missing in that region. So not so much oligos, and this goes back to the question that was asked after the last presentation, and I'll get to that in a minute. So there is some oligos here. There's complete loss of, it looks like loss of iron, and of course the signal that we can see over here. So where is the iron really? So we wanted to do double staining. So the Dab Turnbull iron stain is in brown, and NUN for neurons is in blue here. So if you zoom in, and you can see that it does not co-localize. So we know where the iron is. I just want to show you some of the cool pictures that I've taken. So, so it does not co-localize. So the iron is away from the neuron. It doesn't, and then there's astrocytes. So again, iron is not co-localizing with astrocytes. And this oligos, and you can see that there's definite overlap of brown and blue signal here. So iron is in oligodendrocytes. So this is the normal appearing cortex, right? We also know, okay, so this is another area of so just to show that it is, you can see the very good co-localization right here. And we also know that iron is in macrophages. So macrophages do scavenge iron, but what we saw here is that not too many macrophages at all in the brain parenchyma. There is some in the blood vessels, and that's okay. And when you look at the brain parenchyma, there are very few macrophages that have iron, for sure, that's co-localizing. Some that doesn't seem that much co-localized, but inside the blood vessels, there are quite a few that are co-localized. So not enough macrophages here to give those punctate hypointensities. So all the signal that we are looking at is iron in oligos, right? So this is the same case for the slab with the cortical lesion, and you can see the co-localization of iron and ASPA here, but not NUN or CD68. So there are more CD68 cells here, but and there might be more with iron, but not nearly the density that is needed for getting the signal there, right? Okay, so when we count these things, so what we see is that normal cortex has about 90% of the oligos in the normal looking cortex have iron. So that is 84 out of total of 94 oligos here that had iron, but only about 10% in the lesion cortex had iron. So there was a lot of oligos here that did not have iron. And the thinking is that this is probably remyelinated oligos. So there could have been oligos and iron co-localizing everywhere, but the inflammatory attack wiped out all the oligos. And when the oligos came back, it did not come back with the amount of iron that we think was there before, right? Okay, so if iron is really so different between normal appearing cortex and in a cortical lesion, then we should be able to design a sequence because MRI is very sensitive to iron. We should be able to design a sequence that can exploit this, right? So and give us good visualization of the cortical lesion, and that's what we did. And we did an inversion prepared T2 star sequence, which is essentially a flare, but instead of a Spinnaker readout, we have a T2 star readout. And we also want to do it at high resolution, sub-millimeter isotropic resolution, because cortex itself is thin, so it doesn't help if you do even a 1 millimeter isotropic resolution. And so this is the images. So this is the IR prepared T2 star, and this is the routine T2 star. And what you can see is definitely that the normal white matter lesions are seen in both, and maybe seen better in the IR T2 star. There are these hyperintensities around the ventricles that are seen on the IR T2 star, is completely masked out in the regular T2 star because of the CSF signal. There is cortical lesion right there that is not, I mean, it's seen here, but you would not call it a cortical lesion because it looks like CSF. So here you can see it. There is another one right there. And there is another one right there. So it gives us more hope that we can do a better job with inversion prepared T2 star. And when we compared all the existing sequences, there are two cortical lesions. So this is the same patient. So the same region being shown here with various 3T scans and then the 7T scan. So we have this hyperintensities in the IRT2 star that can be seen in some of the sequences like PSIR, but it is really well seen in the 7 Tesla. But now we can also see it on the 3 Tesla. And IRT2 star really does pick up lesions in various parts of the brain. So this is some deep white matter lesions, some cortical lesions next to the ventricles, lesions in the brainstem, and in the infratemporal region. So it seems to be versatile enough. And when we look at it, IRT2 star, or suite as it's called here, picks up the most number of subpia lesions. Is the best to pick up subpia lesions, and in conjunction with MP2 rage and flare, all the cortical lesions, not just the type 3 and 4 and 1 and 2 and all 1 to 4, it does pick up very well. So the type 1 and 2 lesions are picked up better by the MP2 rage sequence. And even then, I just want to say that we are not picking up more than like 45% of the number of lesions that you can see on the 7 Tesla. So that is not a good thing. So there is a lot more work that needs to be done, and we are actually trying to do this in a multi-center fashion to see if it is consistent and good, reliable measure. But one good thing is that if you look at the cortical lesions on the 7T versus 3T, you have pretty good correlation. So the R is about 0.86, which means that even though we are missing half of them, the ones that the count that we have is correlating with the total cortical lesion volume as picked up on 70. We don't have a ground truth here because we don't, these are still live patients. So that's encouraging at least. So I just want to summarize here. So most of the talks, develop some imaging technique and validate using postmortem. Here I've shown how we can use postmortem and pathology to kind of come up with something novel in vivo. And I want to thank you for your attention, and I can take your questions. Thanks.
Great. Thank you so much for that great talk. In the interest of time, maybe 1 or 2 questions if there are any.
There is not much, but I have one. So first of all, I found that it was very interesting. I never saw this kind of cortical lesion, so I think it's really cool. And I was wondering, more like standard approach that we take, for example, trying to extract morphometric information, let's say cortical thickness or surface area or this kind of measurements. Do you know if these cortical lesions would impact? I guess they will be, but do you know of any studies who try to characterize that? And because I guess because it looks like there is neuroinflammation and edema, so that will probably tell us there is increased cortical thickness in these regions. So I don't know if you can elaborate on that.
I think that's a great question. So the cortical lesions do change the cortex, and ultimately there is neurodegeneration, so there is thinning. But the thinning that we expect is sub-millimeter, right? So any imaging that we do, and these lesions appear at various places, so it's not like they always appear in the visual cortex. So, you can do a group average study. So this is the problem. So these lesions are inconsistently appearing in various parts of the brain. So we really need a high resolution technique to look for thickness changes. And if you think that it's going to change by even 10%, which is like 0.3 mm or something, right? So it is very difficult to do that. However, there are studies that are doing it. There is also a study that is looking at changes to the curvature of the cortex. So maybe that is a little bit more detectable because there is all these changes happening. So yeah, there are studies, and there's also studies that have done on T1 over T2, right? So that's the Vanneson, Matt Glaser way of looking at lesions. So there are various studies that look at it, but what I'm getting at is we really need high resolution to say something about an individual.
Thank you. So we have more questions now. From Mert Sisman, did you check the colocalization of macroglial cells and iron?
Yeah. So So this is the co-localization of, sorry, I didn't put it here. Yeah, so microglial, we did look for macrophage in specifically, but yeah, so I think that there were some, but not in the extent that would change our signal. Yeah.
Thank you. Maybe your last question from Mark Nelson. Is it possible that part of the difficulty with characterizing MS is because it is a more heterogeneous disorder than we think? And if so, do you think that a greater emphasis on genetic subtyping could help?
Yes, I think that's a great question. So it is heterogeneous, and there are different types. I didn't even get into that. Yes, and I think if you stratify these studies, depending upon, say, those who have more cortical involvement than white matter involvement, that helps not only target, specific therapeutic targets, because you might have something that's for white matter, but maybe doesn't work as well for cortical involvement, right? So it is important to stratify, and we are always looking for markers. If there's a genetic marker for this kind of thing, it would be helpful. But one way that we're trying to do it is through imaging. So if you can identify somebody who has more cortical lesions, and that would be a different kind of subject population, right? So yes, that would help, I think.
Great, thank you. I think for matter of time, we are going to move on. But thank you again. It was a great talk.